This is where I think the independent piece comes into play, or at least a different model for Sycamore. And we're trying to enable facilities to contract directly with physicians. We charge a flat, transparent fee to do that. If facilities have the ability to contract directly with the physician without us, great. We're solving that problem where you need help doing that. You're able to pay, in our case, more than 90% of that budget to go straight to the physician versus not knowing. But the bottom line to what you were saying is that you do get what you pay for. If you're paying for a quality doctor, you're going to get better results. And I think in locums, most are resigned to the idea that locums is a necessary evil. It's going to probably hurt us financially. It's gonna hurt the team. It's not the locums doctor is probably going to leave us worse than they found us. And I think what you're describing is a scenario where a locums provider can actually elevate the team, can actually improve outcomes and metrics. If you've been in medicine for very long, that's not something that you would anticipate being possible.
There are clearly people out there that are very skilled at doing the locums thing, and to some degree, it's I don't. So it's a great question: is can you train somebody to be a great locums? The answer is yes, because everybody's trainable, but it does have a lot to do with personality. So there is a personality type that probably is better at being a locums. You have to be able to come into an environment where you really don't know anybody and make everybody feel like you know them, and that's a challenge. And so that's part of the skill set. Having good communication and good knowledge base on what you're getting into. I think, for locums, this is where, a motivated individual should be doing a lot of research on the facilities that they're going to, and not just saying, if you're a kind of locums that was a failed doc and you needed to go wherever you could to make money, then you don't really care where you go. But if you're a motivated, highly trained doc, you should want to go someplace where you have a good chance of succeeding. So you should know, and do your homework over, all right, so I'm going to this facility in rural Kansas. What's my situation like? Where's my local referral center? What's the hospital's capabilities? What kind of equipment and supplies do I have in the department? Am I getting into a nightmare? I mean, when I was a director and taking over facilities, that was a big part of it. Is this place fixable? And those questions aren't always answerable easily. Some are. I mean, if you want to say, well, is a facility fixable? 90% of that is, does the administration want to fix it? Are they willing to put the time and effort into fixing something? Most things that don't work, there's reasons they don't work. Those reasons aren't simple. If they were simple, they would have been fixed by somebody at some point. I mean, that's a generalization, but in general, most things are that way for a reason. So if you're a locums doc and you're going to a place that has had 3 different contract groups in there in the last 3 years or 6 years or whatever, they're on 2-year contracts. There's been a huge turnover of doctors. The nurses are upset and they're frustrated. The administration doesn't get a sense of why they keep failing. And you go in there as a locums doc, okay, you got to go in there knowing there's challenges. So, I'm not saying it's a place you wouldn't go, but you should have a good sense of, okay, I'm stepping into a place that's got challenges.
I think that's part of the skill set of this new breed of locums that we're talking about are people who are good at identifying those challenges and good at having a realistic expectation of what kind of impact they can make on those or not.
We talked about this, and again, my unique skill set. I always look at stuff. There's a locums issue because I'm a locums provider right now. But there's also the director part of me, and the startup and turnaround part of me says there's probably a locums like consultant sort of thing that goes in and tells the hospital, well, here's why you're failing, or here's why you're having ongoing challenges, and here's why you're not attracting docs, your operations in this, that, or the other thing. And particularly the consulting groups that are out there, there are some big ones that do these. Like I said, finding the problems aren't necessarily that difficult. Finding solutions that are realistic and doable is a different thing. You almost have to work there. So working in those environments, you'll learn more working than reading the tea leaves.
It comes back to that skin in the game piece. I mean, it all of a sudden becomes less academic and more of a experience. Uh, learn from experience, and you're also thinking about it from a perspective of how is this going to impact me personally as a clinician.
The emergency department interacts with every part of the hospital pretty much. There are certain areas maybe very little interaction, but some a lot. So if there's a dysfunction that's built into that, so let's just, for example, say that the hospitalists don't want to admit anybody. It's a very difficult hospital to get a patient admitted. But that's going to make the emergency department physician's job more difficult, no matter who they are. And so if that's the problem when you get there, and that's a simple problem to figure out, you just ask the existing physicians, is it easy to admit a patient to the hospital? And they go, no, it's a pain in the neck. Why? Well, then you find out. So then you have to go to the hospital and say, well, we have a interface here that's not working smooth. That is causing friction in the department and slowing down operations. So once that is identified, then you have to say, is there a willingness on the part of the hospital to address that? And that usually means having collaborative meetings and deciding what is the problem, figuring it out and solving it. And if you fix that, which I've done at a couple different sites, then all of a sudden the ER physicians find, wow, it's a little easier to admit the patients. The flow in the department works. The workflow in the emergency department now is a little easier. The nurses find it. They're not backed up. And, all this stuff kind of works. Now you've fixed a piece of dysfunction. And the ER physicians find, it's a more pleasant shift. I'm not fighting, to get the patients admitted. So those are, little examples of how the hospital itself needs to be involved in that.